Good morning and profit.
Good morning, students. I'm Dr. Lavanya, Associate Professor in the Department of Anesthesia. And today we are here gathered to know about, discuss about the airway assessment of any patient coming for anesthesia or under anesthesia for surgery. So, what is airway? Airway is a passage in which the air passes during respiration. It includes the upper respiratory tract and the lower respiratory tract, which includes includes the nasal cavity, pharynx, larynx, and the lower respiratory tract will include trachea, bronchi, and lungs. So today we are going to discuss about all these airway little bit and their assessment. So parts of the upper airway will be extending from mouth, which has a vestibule to the anterior, which extends from the vestibule to the anterior dorsal nose, which extends from the adult nose is around 1.5 to 2 centimeters in diameter, and the nasal cavity from the nasal nails to the choana. Nasopharynx. It extends from the choana to the posterior pharyngeal wall above the soft palate and superiorly from the skull base of the skull to the plane of the hard palate. Oropharynx, plane of hard palate to the tip of the epiglottis. So this is the diagram showing the upper respiratory tract, which includes nose, nasal cavity, oropharynx, nasopharynx, and laryngopharynx. Below the larynx, it is called upper respiratory tract. Larynx, which extends from the laryngeal inlet, which corresponds to C3, C4 vertebra to the lower border of the sigmoid cartilage, which corresponds to C5, C6 vertebra. The importance of the larynx, always you know, it is important for formation and swallowing. Larynx is consists of 6 cartilages, of which 3 are unpaid and 3 are paid. The unpaid cartilages are the thyroid, cricoid, and the epiglottis, and the paid cartilages are the arytenoids, corniculate, and the cuneiform cartilages. Most vulnerable area for obstruction and trauma during laryngoscopy is the larynx. So now we extend to the lower airway tract, which includes trachea, bronchi, and the bronchioles. Trachea, it extends from the cricoid, which is C6, corresponds to C6 vertebra, and to its division into the main bronchi, which is at T4. It is around 11 to 13 centimeters, and the endotracheal tube lodges in the midpoint of the trachea. Bronchi and bronchioles are made up of fiber cartilages and have secretory bronchial gland cells. These are some of the differences between pediatric and adult airway, which includes some of them are where the nails are wide in adult and narrow in the pediatric. The angle of jaw will be acute in adult and obtuse in pediatric. The tongue size is smaller in adults, larger in pediatrics. Palate is ossified in adults, non-ossified in. And the epiglottis is large, floppy, and more sepal place in pediatrics, whereas it is thinner in adults. Position of larynx in neonates, it is C3, and at 6 years of age, it reaches to C4 and C5. Whereas in adults, it is C5 to C6, which is in pediatrics, it is much more placed than in pediatrics, which is again an indicator of difficult care. And the position of larynx, then description of the larynx, it is more anterior and sepal placed in pediatrics. Vocal cords is anteriorly slanting, while not so in adults. Epiglottic folds will be thicker in pediatrics. So it is very difficult to introduce the laryngoscopy during endocrine investigation. Submucosal tissue is more, and the increased chance of edema is more in pediatrics. Whereas cartilages, it is harder and stable in adults, whereas soft, collapsible, and easily and soft in pediatrics. So it can be collapsible easily. Human will be narrower and circular. Whereas in adults it is wide and elliptical. Subglottis is funnel. There is no funneling in the subglottis. Cricoid will be narrow before puberty and wide in adults. Narrowest part in the pediatric airway is the subglottis, whereas the glottis in the adults. Tracheal length is reduced by 4 centimeters, and the angulation of bronchi is more horizontal. Diaphragm is placed much more higher than compared to adults. Ribs are more horizontal, and whereas in adults it is slanted placed. Alveolar are lesser in number, it is around 20 to 50 million, and whereas it is more than 300 million in adults. So why we want to know about the airway? Why it is necessary to assess the airway before we are planning for any anesthesia? But the main purpose is to diagnose the potential difficult airway, thus optimizing patient preparation, proper selection of equipment, and participation of personal experience in difficult airway management. So, what is the definition of difficult airway? According to American Society of Classification, American Society Association, the definition of difficult airway is the clinical situation in which a conventionally trained anesthetist experience difficulty with mouth filtration, difficulty with tracheal intubation, and uh, and for the difficult ventilation, definition goes like this. The inability of a trained anesthetist to maintain the oxygen saturation more than 90% using face mask for ventilation and 100% inspired oxygen, provided that the pre-ventilation oxygen saturation was within the normal levels. And difficult intubation defines more than 3 attempts and which is longer than 10 minutes or failure of optimal best attempt. So, area assessment includes a thorough history examination, general history taking, general and physical and regional examination of the area. There are specific tests for the assessment of area. It is segregated into anatomical criteria, direct laparoscope and hydroxyl bronchoscopy, radiographic assessment, predictors of airway in diabetes, indicators of difficult intubation, 6 standards in the evaluation of airway, quick airway assessment of pediatric airway. So in history, it should be conducted whenever it is feasible before the initiation of anesthesia phase and airway management, in order to detect any medical, surgical, or anesthetic factors. And anesthetic factors will be much more urgent in edema, bone, bleeding, and tracheal esophageal stenofication or compression or perforation, hemotherapy, or aspiration of gastric content. Examination of previous medical reports is possible. It is always better to see the previous reports of surgery and the anesthetic management. So, these are certain conditions where the airway is almost in a compromised state. So, you should be more cautious. Some of them are the congenital syndromes like Robin, where there will be microchondria, microchondria, and soft palate of the joint. Just the soft palate will be present. Pressure cooling syndrome, where there will be ocular defects with malar and mandibular hyperplasia. Golden heart syndrome, where there will be mandibular hyperplasia, malar. Down syndrome, where there is accent breach of the nose and macroglasia. People syndrome, where there is congenital fusion of all the cervical vertebra, there will be restriction of neck movement, and there will be a compression of trachea and the deviation of larynx or trachea to one side due to existence of enlargement of swellings in the front organ. And some of the acquired lesions will be infections. Like supraglottic axis or retropharyngeal axis like that will be laryngeal, where there will be laryngeal edema and distortion of the airway and listener. Some of the conditions like rheumatoid arthritis or ankylosing spondylitis, where there will be temporomandibular joint ankylosing, precarotenoid arthritis, which leads to the restricted mobility of the cervical spine, and there will be a depression of the larynx, and which finally leads to immobility of the cervical spine, making it as a difficult gateway. And some of the benign tumors like cystic fibroma, where there will be stenosis of the airway, any swellings like lipoma, adenoma, and goiter. Malignant tumor, any malignant tumor will be considered because there will be an edema of the members of the airway and which are fragile. In distortion of the face, facial injuries, hematoma or unstable fractures like that. Obesity, where there is a short and big neck, where there is redundant tissue in the oropharynx, which leads to the sleep apnea, finally leading to sleep apnea syndrome. Acromegaly, macroglasia, and prognastical inflammation. Acute birth, there is always edema of the airway, which can be. So these are some of the pictures where we can predict the airway is very much difficult for endometrial integration. First picture is showing triple fail syndrome, where there will be a fusion of all the cervical vertebra and leading to restricted neck mobility. So patient will be, it is a very difficult airway to get. Golden Knot syndrome, where there is smaller mandibular hypoplasia, auricular and ocular defects will be there. Trichepholin syndrome, there is mandibular hypoplasia and cleft lip, cleft palate, overriding of the dentition. Pyruvate syndrome, there will be a mandibular hypoplasia with prognatism and occasionally it is associated with cleft palate. So these are all some of the airway difficulties which need to be addressed. In general physical and regional examination, we should examine the airway thoroughly, which includes the upper respiratory airway tract. Look at the patency of the nails, whether there is look for any mark or any deviated nasal substance or any solid nasal solid like that. In the mouth opening, it should be two large finger breaths between upper and lower incisors in adults. Teeth, look for the teeth, whether there are prominent incisors, canines with or without overbiting or edentulous teeth. And palate, look at the palate. It is high arched palate or long, narrow center palate, which makes difficulty during laparoscopy. Patient's ability to protrude the lower jaw beyond the upper incisors. This is known as prognatism. Look at the temporomandibular joint, which must be restricted in TMJ ankylosis or some tumors or in conditions fibrosis, where it leads to fibrosis. So this can be tested in two different tests. It is finger test or the cavern test. Finger test, first place the index finger in front of the daggers and the thumb is placed in front of the lower part of mastoid process. And now the patient is asked to open his mouth as wide as possible. Index finger in the front of tragus can be indented in its place, and the thumb can feel the sliding movement of the condyle as the condyle of the mandible moves slides or forward. Any crepitus or click or grinding movement palpated on movement indicates TMJ. This is the figure showing the TMJ, the finger test. In the finger sliding without any crepitus is normal. With crepitus, it includes TMJ ankylosis or any tumor or any fibrosis. The calendar test, this is used to test the subluxation of jaw. The patient is asked to protrude the lower jaw as far as possible beyond the upper jaw. It is graded as 2 and 3, indicates reduced view at laryngoscopy. So this is the mandibular protrusion test or the Gallagher test. Class A, grade 1 is lower incisors can be protruded anterior to the upper incisors. Class grade 2 is lower incisors can just bought edge to edge with the upper incisors. And grade 3 is the lower incisors cannot be bought edge to edge with the upper incisors also. So grade 2 and 3 indicates the difficulty in laryngoscopy and finally the airway. Then the upper lip bite or the catch test. It is classified as 1, 2, 3. So class 1, lower incisors can bite the upper lip above vernier line. Class 2 can bite the low upper lip but below the vernier line. And class 3 cannot bite the upper lip. What its significance is, what it signifies is the patient having grade 3 upper lip bite test may be expected to have format line grade of 3 or 4 laryngoscopic use of larynx. So, grade 3 of upper lip bite test corresponds to format line grade 3 and 4. Assessment of mandibular movement and dental architecture, there will be less inter-observer variability here. So this is the upper lip bite test. In the first figure, the upper lip can be written over the vernier line, just touching the upper lip below the vernier line and not even touching the lip first. Then assess for the neck. Is how is the neck, whether it is short, deep, or long, slender, both are wrong. Both ways it is difficult integration. It should be optimal to the patient structure. Many markers in neck, the extension of neck, the neck mobility, ability to assume sitting position should be observed. Neck circumference is measured at the level of most prominent point at the top of thyroid cortex, which patient looks straight. It is less than 42 centimeters in males and less than 40 centimeters in females, which is considered as normal. Presence of awareness of body striker previous tracheostomy will suggest a stimulus. Any systemic or congenital disease requiring special attention during labor management. Infections of the airway like epiglottis or abscess growth may also lead to difficulty and the certain physiological conditions like pregnancy or obesity may lead to difficult. And look externally. These are like presence of any facial hair, long birds, etc. Short and fat neck, morbidly obese patient, facial neck or neck problem, broken teeth, can lacerate balloons, etc. All these will be reviewed and there will be as well the difficulty. Dentures, whether it is present, it should be removed. Large teeth, protruding tongue, a narrow or abnormally shaped face. These are all some of the pictures where we can assess difficulty in laryngoscopy and neglected infection. If man is having a long back, short neck, fat, the neck, which without the face with multiple fractures, protruding tongue. Specific tests for assessment is what? The anatomic criteria are relative to the tongue and pharyngeal size. How is the airway we can assess? First one is Malampati test. In this test, the objective grading is done relating the size of tongue to the oropharyngeal space. And it is classified as class 1 to 4. Class 1 includes partial pillar, soft palate, and uvula visualization. Class 2, partial pillar, soft palate, uvula are masked by the base of the tongue. And class 3, only the soft palate is visible. Class 4, only the soft hard palate is visible. Even soft palate also not visible. Class 3 and 4 of the pictures of distal laryngoscopy and intubation. So this is the diagramic picture of the same allopathic classification. Class 1, where partial pillars of the palate, uvula, Based on the time, everything is visible. Class 2, partial figures, uvula can be marked by the base of the tongue. Class 3, only top palate is visible. Class 3, only part palate is visible. The second test is Atlanta-occipital joint. It assesses the feasibility to make slipping or nodal position for intubation with alignment of oral, pharyngeal, and laryngeal axis towards trachea. The patient is asked to hold head erect facing directly to the front, and then he asked to extend the head maximally, and the examiner estimates the angle transferred by the occlusive surface of the upper teeth. So visually assessment using a goniometer, which includes grade 1 is more than 35 degrees, which is normal. Grade 2 is 22 to 34 degrees. Grade 3 is 12 to 21 degrees. Grade 4 is less than 12 degrees. These limitations can be expected in spondylosis and infrared arteries patients. This is the Atlanta Hospital joint extension angle measurement with the goniometer. If the angle is more than 35 degrees, it is said to be normal. If the angle is reduced to one third, there is reduction in the extension in one third. If the angle is reduced to two-thirds, there is reduction of the joint extension also two-thirds. There is no extension, complete reduction. Complete joint. There is no extension, there is no angle. So in this angle, the oral, pharyngeal, and laryngeal axis comes in a single plane, which can be accessed from the upper edge of the upper tooth, upper jaw tooth. Next, the third one is the mandibular space. This space determines how easily the laryngeal and pharyngeal axis will fall in line with the Atlanta-occipital joint is extended. It includes four tests, which are thyromental distance or the pattern test, sternomental distance or the Saba test, hyomental distance, and the interinsular. Thyromental distance or the pattern test is the distance between the thyroid and the muscles when neck is extended. So it is more than 6.5 centimeters. It is no problem. It is normal. Laryngoscopy and intubation are easy. If it is 6 to 6.5 centimeters, then you may feel difficulty in laryngoscopy and intubation. Less than 6 centimeters, definitely laryngoscopy is possible. Then sternomental distance or the SAVA test. Distance from the upper border of the mammalium to the tip of the mentum when neck is fully extended and mouth closed. Minimal acceptable value for this is 12.5 centimeters. Single predictor of the difficult laryngoscope and intubation, which has high sensitivity and sensitivity. The sternomental distance is the single predictor of the single best predictor for difficult laryngoscopy and intubations. This is the normal sternomental distance, which is around 12.5 centimeters. Measuring from the mammalian sternum to the mentum when the neck is fully expanded with mouth closed. Then the hyomental distance. This is the distance between mentum and the hyoid. Grade 1 is more than 6 centimeters. Grade 2 is 4 to 6 centimeters. Grade 3 is less than 4 centimeters, which is just like that thyromental distance. Then the interinsular gap. It is the interinsular distance with maximal mouth opening. Normal value is more than 5 centimeters. That means 3 fingers. 4 to 6 centimeters or 3 fingers. Normal thing. Grade 2, easy laryngoscopy and intubation. Less than 2.5 centimeters, difficult laryngoscopy. And if it is 2 centimeters, laryngoscopy cannot be done. And it will for otherwise insertion. Which is the interinsular gap, which is normal more than 5 centimeters. Then the lemon airway assessment method. The score with a maximum of 10 points is calculated by assigning 1 point for each of the following. Patient in the difficult intubation group have higher lemon scores. It is the sensitivity and specificity is about 90%. So, lemon in that L is look externally. So, externally look for any facial trauma, large visitors, bad, musical, large, and he is for evaluate the interinsular gap, three finger breadth, and hyometrical distance, which is the left breadth, and two is the thyroid to mouth distance. 3 3 2. Malampati score of more than 3 is always difficult. O stands for obstruction. Obstruction, any presence of any conditions like epiglottitis, peritonsillar abscess, wrong, etc. When looks for neck mobility, so that neck mobility is restricted or easy. So the same thing in here. Direct laryngoscopy and the fiberoptic bronchoscopy, which these difficulty in intimation can be classified according to the flow obtained during direct laryngoscopy and graded into 4 grades, which is defined by Cornick in 1984. Optimal position where active mouth, larynx, and pharynx will be achieved in single line by the flexion of neck and extension of head and the occipital joint is important. It is grading by direct laryngoscopy. Grade 1 is full exposure of the glottis, anterior and posterior commissured. Grade 2 is anterior commissured, not visualized. Grade 3 is epiglottis only. Grade 4 is no glottic structure visible. Grade 1 is equal to is more success and leads of integration. This is the same grade showing corner grade. Grade 1 is grade 1 full anterior and posterior commissured commissured. No anterior commercial vertical, there is no epiglottis also is not just a tip of epiglottis visible, not even epiglottis visible. The same thing in laryngation frequency. Grade 1 is the full glottis, grade 2 is the anterior commercial. We can't see, just tip of epiglottis frequency. Only the epiglottis. There is no glottis. Cook has further subdivided Cornick and grade 2 and 3 as per A, B, and A, B. Where we have visualization of posterior part of the culture, and it means only epiglottis visible and epiglottis adequate or only visible respectively. As per Cook, 1 and 2 A patients can be directly intubated. 2B, 3A required FBG, 3B, 4 cannot be intubated using conventional laryngoscopy and breathing, but use other alternative specialized techniques. Grade of use of intubation. Grade 1, extensive manipulation of larynx not required. Extensive manipulation of larynx required in grade 2. Intubation possible with stimulate guided intubation, failed intubation in grade 2. Then there comes the radiological assessment. This is from the X-ray films of mandibular. You can see the mandibular hyoid distance, atlanto-occipital relation of the mandibular angle and the hyoid bone with cervical vertebra and laryngoscopy grading. Anterior and posterior depths of the mandible, even frequency. Then there is a fluoroscopy for dynamic image, core mobility, infrared, nothing basically and the signal. Isofibrogram. Inflammation, foreign body extends in most of vascular integrity. These are the 5 points which can be measured in the central phase. One is the effective mandibular health. 2 is the posterior mandibular depth. 3 is the anterior mandibular depth. 4 is the atlanto-occipital gap. 5 is the C1C2 gap. And next method is ultrasonography. Assessment of anterior mediastinal mass lymphadenopathy differentiates this from mass and cellulitis from abscess. Computed tomography or MRI, which may be helpful for diagnosing congenital anomalies, vascular area comprehension. Video optical intubation stylet combines viewing capability with the familiar handling of intubation devices. The predictors of triple David diabetes improve the palm print and the prayer quality. Palm print and the fingers of the dominant hand of the patient is painted with black writing ink using a brush. The patient then presses the hand firmly against a white sheet of paper on a hard surface. The scoring is done as follows. Grade 0 is all pharyngeal areas visible. Grade 1 is deficiency in the interpharyngeal areas of physical injury. Grade 2 is deficiency in the interphalangeal digits of second to fifth digits. Grade 3 is only tips of the digits seen. Certificate of difficult in the diabetes. This is the concept. There is no digit interdigital print in fourth and fifth. So it is grade 1. Whereas the beside one is the normal part. Then the prayer side. A positive prayer sign can be exhibited on examination with the patient unable to approximate the palmar surfaces of the pharyngeal joints by placing their hands together. This represents cervical spine immobility and potential for a difficult endotracheal intubation. Positive when there is a gap between the palms. Negative when there is no gap between the palms. Then the classical signs arguing the operator to difficulty of intubation may be summarized as follows. Full flexion, neck extension, mobility of the head and neck, a receding mandible and the presence of prominent teeth, a reduced Atlanta-occipital distance, a reduced space between C1 and occiput, large in size tongue, related more to the ratio of the anterior length of the tongue to the length of the chin or mandible. Then temporomandibular mobility, one finger, inspection of mouth, oropharynx, Malapati classification, two fingers, measurement of mental distance, 4 centimeters in adults, then 3 fingers, measurement of distance from chin to thyroid notch, 5 to 6 centimeters, 4 fingers, ability to flex head, reverse chest, extend head at Atlanta occipital junction and rotate head, turn right and left to 5 movements. Symmetry of nose and frequency of nasal passage. The group indices we use are Wilson score, Venmo score of 11 parameter analysis, Dagger and sample test, Medwall score. Wilson score, which includes the following parameters, weight and head weight. For all the scores are given as 0, 1, and 2. 0 is less than 90, 90 to 110 is 1, more than 110 is 2. Again, next moment, 0 is above 90 degrees, 1 is above 90 degrees, 2 is below 90 degrees. Jaw movement, 0 is interincisional gap more than 5 centimeters, 1 is equal to 5, 2 is less than 5. Receding mandible, 0 is normal, 1 is moderate, 2 is severe. Buck teeth, 0 is normal, 1 is moderate, 2 is severe. And the score of less than 5 is easy laryngoscopy, 6 to 7 moderate difficulty, 8 to 10 is severe difficulty in laryngoscopy. We use Venmo's 11 parameter analysis, where the 11 parameters are the buccal tooth, interincisional gap, length of upper incisors, mandibular proportion test, Malapati class, palate configuration, gyromental distance, mandibular space complaints, neck length, neck thickness, head and neck movement. So all are minimal acceptable values given. For all the 4 for 2 for inside the mouth, and 2 for mandibular space, and 3 for neck examination. So 4, 2, 3. And the study and Safari's test. These parameters include weight more than 80 kg, tongue proportion less than 3.2 centimeters, mouth opening less than 5 centimeters, upper incisor length is more than 1.5 centimeters, Malapati gas of more than 1, head extension of less than 70 degrees. Any 3 indices is present, includes prolonged laryngoscopy. And the last is this Malbos Florence test. For intubation, remember the flow rate, which is Malapati, measurement, movement, and malformation and stop. First thing is malformation of the skull, teeth, obstruction, and pathology for the macros and micros. We can memorize them with the word stop. S is skull, hydro or mega or microcephalus. T is teeth, public protruded loose teeth, macro and microcephalus. O is obstruction due to obesity, short breathing. P is pathology, which includes radiofacial abnormalities, symptoms like rectal swellings and fibrosis. Patient score of more than 8 is less difficult intubation. And difficult mass medication, limiting dose, between bad, for variable, low obese, E's for elderly, and L for smokers, C is eventually. The difficulty in maintain mass is due to any anatomical or congenital or acquired factors. Patients having more than two of the predictors are likely to have difficult mass menstruation. The quick Airway assessment can be done by the specialist and the patient to open the mouth widely. If no, there is a DNG analysis. When the patient maximally protrudes the tongue, affects the posterior aspect of the mouth, pharyngeal structures. Ability, patient's ability to move jaw forward indicates these to maneuver the larynx. Can patient fully bend or extend the head and move it sideways indicates neck movement. So movement at for movement at Atlanta Hospital joint, ask patient to move, place the chin on the chest, clasp both hands behind the neck, pull downwards, and try to move head upwards. Always with this one. Thank you, children. So this area assessment reports from Miller's ninth edition and area management by the Russian part and we have under the of course development. So any doubts? So it is an important topic for any analysis to practice general anesthesia. So every assessment is very important. So any doubts? Next topic we have next class. We come in preparation for burns management. How you will manage burns patients and anesthesia for anesthetic management for a patient with goals. Thank you, everyone.